Hello, good afternoon, everyone. It's Dr. Simone. I'm Deputy Medical Director here at the Zita West Clinic, and I will be happy to answer to some of your questions today. Today we are doing it a bit differently. So normally Zita does the introduction. So today I hope you wouldn't mind me doing it, and Zita will join us very shortly. So you can, if you want, you can start maybe sending some of the questions you would like to ask today while we are waiting for Zita to join.
You can see Zita just joined.
Yeah, we have just seen Zita is joining us. We're just trying to see how we can make this faster. Yeah.
Hi, Simone. How are you?
Hi, Zita. I'm very well. I just today I just did the introduction, which you normally do.
Oh,
so.
well done, well done.
Yes.
And the man in the mask, how's it all going?
Yeah, I still needed to wear the mask because Vic helped me setting everything up. Thanks, Vic. So yeah, so now I can take it off. Now I'm alone in the room now. Yeah.
How's it all going there? You busy?
Yeah. I mean, busy as always. Trying to help as many patients as possible. Yeah. So very busy, but you know, I'm happy to be busy.
Good. Well, I've got lots of questions here, Simone. Sorry, my iPad's running out of juice, so I'm sitting here. So, should we start?
Yeah.
I think what's quite interesting now is that we're nearly in the middle of November, and women are sort of thinking about next year now in terms of their cycles and preparation. And I'm going to be doing a lot next week on this on IGTV. So, some of the questions that are coming through are about preparation. Let me just find them here. Okay, notes. Okay. Right, so one of the first ones, and I know that you do a lot with this, is I've been trying for 18 months. I have PCOS. What sort of protocol would you use for a person like me? And I know that you treat a lot of women with PCOS, don't you?
Yeah, I mean, that's always been one of my areas of interest since I was not even graduated in medicine, and I was still having an interest in that. So it has been an area of research for me for about 20 years. So during which I have accumulated, quite a good experience in managing it. So I mean, for PCOS, it's very important the preparation, because things like the inositol, for example, which we give here, are proven to have a beneficial effect on egg quality, which sometimes can be a bit of a problem in polycystic ovary. So I always tend to prepare patients by taking at least inositol for at least 2 months. Prior to the treatment, alongside also with the diet, with the nutrition advice we give. And then once we come to starting the treatment, it's very important to start with the right protocol, because which needs to be a short protocol, because the problem of polycystic ovary is very often associated with hyperstimulation.
Yes.
So and now is well recognized that the best protocol to reduce the risk of hyperstimulation is a short protocol. So it's quite mandatory that a short protocol is given, combined with a relatively low dosage of medications.
Yes, because these women can hyperstimulate, so they don't need a lot of stimulation,
exactly.
do they? Yeah.
Exactly.
It's interesting as well, though, Simone, because a lot of women read now and they know so much, they have so much information, but the IVF you have has to be appropriate to you. You can't just sort of think, right, I'm going for natural or mild or conventional or whatever. It has to be appropriate to you, doesn't it?
Absolutely.
It's really important.
Yeah, and that's what we try to do here. We don't have standard protocols like in other clinics do. That is a key factor, as you said, Zita. The treatment needs to be very needs to be very personalized to the patient we have in front of us.
Yes.
That's key, and that's what I try to do from the very first consultation. Try to understand the kind of patient I've got in front of me, what are the characteristics, and then just to try to tailor the protocol according to the patient needs.
Yeah, okay. There's a question here. I've had the ERA, Emma and Alice test and a test for CM42. Are there any other tests I can have done to rule anything out before embryo transfer?
Well, I mean, the tests have to be driven really by what the doctor thinks the problem might be. At least that's what I do. When I have a consultation with the patient, I try, particularly after a failure, I try to understand why the patient might have failed. And if I ask the test needs to give me an answer about what could be the reason. So Ira, Emma, and Alice might provide...
Can you just explain to some of the listeners what that means and why those tests are used?
Yes, normally Ira, Emma, and Alice are tests that give the clinician more information about whether the uterus could be the factor not allowing an implantation or potentially being responsible for a miscarriage. Okay, because with ERA, you just identify whether the timing of the embryo transfer is the right one for that woman. Because some women have their implantation window, which is slightly anticipated or delayed. So if you do a transfer on the standard day, which is day 5, in case of blastocyst, that can be a little bit early or later for that single patient. So the ERA will help us assessing that, and clearly if the ERA shows that that patient would need a transfer earlier or later, we need to address this, and we have to personalize the timing of the transfer based on the ERA results. Emma and Alice actually give a different information. Emma tells you more about the eventual presence of an infection, whether Alice can tell more about the bacterial flora in the uterus, because it is believed that things like lactobacillus, having the right amount of lactobacillus, actually might play a role in implantation. So with that, we can determine whether the amount of lactobacillus is what it should be, or if it's lower than that, we can give some some supplements just to integrate this and to implement the presence of lactobacillus in order to have an optimal balance by the time of the transfer.
It's interesting, isn't it? This whole microbiome is growing and growing and growing, isn't it, in terms of evidence and research, and how important it's becoming, not just in fertility, but in all areas of medicine. So I love these names, Emma and Alice. I didn't know what people were talking about when these tests first came out. We talk about people's names. I've had Emma and Alice. Anyway, I know now. So what have I got here? Okay, no, I'm sort of on the wrong page here with my questions. Okay. Another question here, Simone, is about low AMH. I'm 32. I've got an AMH of 5.7. I've been trying for a year. Will I be eligible for IVF?
Well, as I often say, AMH, apart when is dramatically low, but with that I mean levels below 0.5. But when is not that low, AMH is never a predictor of how successful an IVF cycle can be. The only thing that AMH can tell is how many eggs we might be likely to get Okay. But apart from that, it doesn't tell you anything about the quality of these eggs. So you can have a very low AMH, but still have a successful cycle if, for example, the few eggs a patient can produce are of excellent quality and they create very good embryos. So the AMH doesn't need to be used as a predictor of IVF success. It's just an indicator of ovarian resource. So how many eggs are we likely to get?
And also doing an antral follicle count as well gives you
Exactly,
a good indication. But
which
I know
is even more accurate. I rely more on the scan rather than on the AMH, to be honest, because the AMH sometimes can under or overestimate the real situation. So the scan is always the best thing to do.
Yeah. And we've seen a lot of women that have low AMHs that are younger that go on to get a really good amount of eggs. It surprises you, doesn't it? And it's only the first time round that you see how somebody's going to react.
Exactly. And if that patient is 32, I would actually suggest that she doesn't give up, because at 32, you don't need that many eggs to have a successful pregnancy. Yeah. So women at around the age of 30 up to 35 still have very good chances, even if the amount of eggs is reduced. So low number of eggs becomes more of a problem in older patients.
Yes.
But as a patient is still young, even if the AMH is relatively low, they still have, I would say, very good chances to get pregnant.
No, fantastic. There's a lot of questions I've bunched together here on low AMH and egg quality. Anything to improve egg quality?
Well, egg quality is one of the most difficult things. That there is no magic wand, but clearly what we do here is to try to, and nothing happens immediately for eggs. Eggs and sperm have a turnaround time of at least of roughly 3 months, 2 to 3 months, more close to 3 months. So nothing happens immediately. And that is why here we start the preparation well in advance to come to IVF fully prepared and in the best possible situation. So things like nutrition and supplements will need to be started at least 2-3 months in advance to have some effects on in improving the egg quality.
Yeah, because I honestly believe that the environment the egg is growing in is affected by your diet, your nutrition. I'm a huge believer, like you are, in supplements, inositol, coenzyme Q10, omega-3, vitamin D. All of these things are really key, but it's the preparation as well in the lead up to IVF, which is really, really important.
Exactly. We can't expect to find something that in a week time will change the egg quality. The drugs can't do that.
Yeah.
Because the drugs can only stimulate what the patient already has.
Yeah.
But those eggs we are stimulating started being produced 2 months before.
Yeah.
So what we can do with the drugs over 10 days of stimulation is very limited. We can just grow what we have, but basically what we have is the result of what the patient has done in the previous 2 months. Again, if you want to do something to try to improve the quality, that would need to be started well in advance.
Yeah. So women that are thinking about doing IVF in January now, because it's the middle of November, it would be good to get going now in terms of their preparation.
Absolutely.
And then things like acupuncture for blood flow, all of these things make a difference, don't they? Your mindset, everything.
And even for acupuncture, what our acupuncturists are saying to me, and I fully believe in that. By the same token, you will need at least 6-8 sessions of acupuncture to make it work. And I mean, you are an acupuncturist, Zita, so
Yeah.
you know this better than me. But acupuncture, like anything, needs time to work. You can't expect to have 1 or 2 sessions to make the miracle happen.
Yeah.
So even acupuncture needs time.
Yeah, it does. It's interesting, isn't it? Because I know at the clinic that we do lots and lots of acupuncture, but those women that come in for acupuncture just for transfer, and they've never been to the clinic before, had acupuncture before, they are very stressed because they don't know the therapist, they don't know the clinic, they don't know what to expect. So it is good if you can, and I know money comes into this, do things in the lead up. Okay, I've got another question here, Simone. In which cases would you recommend PGD? And if you can just explain what PGD is as well.
Yeah, I mean, the PGD is basically the genetic testing of the embryos before an embryo is put back in the uterus. Okay, it's still controversial. Okay, because it's still considered that, for example, the HFEA still puts a red light on it, which means that there's no proof, there's no evidence that it might increase the chances for a patient to have a successful pregnancy. And to some extent, I do believe in that, in the sense that it doesn't increase the overall chances for a patient to get pregnant. It just might bring a patient to the pregnancy quicker. Because clearly, if you have got 10 embryos, and you don't know which one is good and which one is not, by doing the screening, you can select better and quicker if and which embryo is genetically viable, and you can discard those which are not. And this is particularly advantageous on patients who have a lot of embryos, because if a patient has just one or two embryos, it might be well worth to put them back and see what happens.
Yeah.
Okay. So actually, I'm more of the opinion that the indications for the PGD, the genetic testing, should be restricted to those patients who really might have a benefit from it.
Yeah.
It's not certainly for everyone.
Older women?
Maybe older women, but older women with still a good ovarian reserve.
Yes.
Older women who can produce a good amount of embryos. Because if I got a 42 years old with just 1 or 2 blastocysts,
it's not enough to be able to do it.
I would rather put them back rather than, and it's also expensive. So,
yes.
So you would rather put these embryos back and give them a chance. Also because the test is invasive to an embryo. You need to take away some cells, and this process sometimes can even damage an embryo. So it's something that really needs to be considered, and the pros needs to be more than the cons.
Yeah.
So it is normally something I discuss again on an individual basis with my patient. I inform the patient about what are the pros and the cons and the cost of the procedure.
Yeah.
And once the patient has correctly been informed, then it's for the patient to take a decision whether she would like to have this or not.
Okay, that's fair enough. I'm having a consultation with you, Simone, in the next few weeks. When would IVF treatment start?
Well, yeah, it's very likely, for the reason I've explained before, that it's not going to start before
January.
I would say even February now, because we are in November. So, and it takes 3 months to be fully prepared. So unless this patient has already started working on her nutrition and on her supplements and is already in a very good place. But if that's not the case, I would say I would rather give this patient at least 3 months. So it's likely to be February at the very earliest.
Yeah, and it's interesting because a lot of the clients we see, they are taking supplements, they are looking at their nutrition, etc., before they go down that route, aren't they? So it's quite good. There's a lot of information out there now for women in terms of preparing. Will changing to a high protein diet help improve egg quality ready for collection? I can answer this one. I mean, you know, the thing is as well, with depends on when you start doing your high protein diet. And I know that our nutritionists are very great advocates of protein because of the fact that, you know, with IVF, it's not a natural process. You're producing, you want to produce more than one egg. So your protein needs are greater. But it depends on how long you do it for. You know, if you start anything at the start of stimulation, it's, you know, it's not going to work. Like you say, it's got to be in advance of doing a treatment and building your body up. Okay, so long protocol versus short protocol for someone with diminished egg reserves. Last AMH was 4, no response to high dose of IVF.
Well, it would be interesting to know what protocol the patient had. Is the patient saying what protocol she had when she didn't respond?
No, she's asking what is better, a long protocol versus a short protocol with for somebody with diminished egg reserve.
Well, my personal view, in a patient with diminished ovarian reserve, I would rather use a short protocol.
Yeah.
Because the potential risk of using a long protocol is to suppress, to add another layer of suppression to the ovarian reserve, which is what is done with the long protocol. The long protocol entails at least 7 to 10 days of suppression of the ovarian function with some medications before actually the stimulation is started.
Yeah.
If that suppression is too strong on a patient with already some problems in responding, then you might not do a favor to the ovaries by further suppressing them. So I would rather like to have that suppression removed and actually start when the patient has a period to try to have a better response. So in my personal opinion, in a patient with a reduced ovarian reserve, we should be using a short protocol rather than a long.
Okay.
And that's what I normally do in patients with a reduced ovarian reserve.
Okay, fantastic. Okay, this question has come up quite a lot as well. My womb lining is very thin. How can I thicken my womb lining for next time? I mean, we get asked this a lot, Simone.
Yes. So again, we might have to dig in the history of the patient, because there might be reasons for that. So, for example, if a patient had several surgeries, several miscarriages, which required surgical intervention to remove it, sometimes that can be one of the factors. You can create some adhesions in the uterus, which is also known as Asherman syndrome.
Yeah.
And that would require, resolving these adhesions through a procedure called hysteroscopy before actually having treatment. Because if the issue is there and is not addressed properly, every time the patient is having a stimulation, actually might still have the same problem.
Yeah.
Whereas if a patient doesn't have any history of that, then it's different. Then we still can do something. Basically, we try to improve, for example, the blood flow of the uterus. And in that respect, acupuncture can also help.
Yeah.
So basically, if the uterus is better nourished, there's more blood flow into the uterus. That can translate into a thicker endometrium.
Yeah.
And we sometimes give a drug called, Viagra, which is very popular for men for other reasons. But the reason why we use it for women is to improve the blood flow, which is what the Viagra does. And by improving the blood flow to the pelvis, it actually sometimes improves the endometrial thickness. That's one of the things we use in cases where the lining is very thin. So there are a few things we can try, but it's very important to understand again why is the uterus is thin in the first place.
Yeah, but for some women, they get really concerned that it's not at 10 millimeters, and that's not always the case. You know, women can get pregnant with it not being that high, can't they?
That's very true, Zita. That's very true. I mean, I have had patients pregnant with an endometrium of 5 millimeters.
Yeah, I've seen that as well.
I still remember that. So it's more about trying to reach the full potential of that patient. If a patient, there are patients who will never achieve more than 7 millimeters just because their body, their uterus is done like that. And we don't have to try to force that patient to achieve that. And if she doesn't achieve that, we cancel the cycle. Because if the potential is not more than 7, I would rather be happy with 7 and go ahead with the treatment. So we need to try to reach the potential of that patient.
I think that's a good way to put it. Really good way to put it. I've got another question here on implantation. I am 34. I've had 2 failed IVFs, both cycles. I had blastocysts. Why would my IVF fail? Is it an implantation problem?
Well, again, it would be good to have more information about the quality of this blastocyst. Normally, if I have a patient, a relatively young patient, and I consider young patients still below the age of 35 for IVF, this patient is 34. So if this patient, if both embryos that were transferred were of good quality, then I would start thinking about a potential problem in the implantation rather than in the embryo. And that's when we have a discussion with the patient about immune problems, because sometimes the immune system can attack the embryos, causing a failed implantation. So that's when we discuss with our patient having some additional tests to see whether the immune system might play a role into that. Because if that is the case, there is an effective treatment to sort this out. So, but it would be good to understand again what is more likely to be the problem, whether the problem is the embryo or whether it is the implantation. So we will need more information. We will need from this patient to know the embryo quality.
Yeah, because, you know, it's interesting as well, just because somebody has failed at IVF, it doesn't mean to say they've got immune issues. And I think sometimes people come along and they say it's immune, and it's not at all. It's something completely different.
For example, if both embryos were of very poor quality, then it's more likely to be that the reason. The embryo was not good enough to make a baby. And in that case, we have to think about how we can improve the embryo quality rather than thinking about immune issues. No,
absolutely. Okay, how to improve the chances of pregnancy at 40 with 1 euploid transfer, genetic testing done?
Okay. Again, it would be important to know a bit more of the history of the patient. But generally speaking, if we have only 1 embryo, particularly at that age where, you know, we can't be sure that we are going to find another one, then sometimes patients want to have everything done. And in that everything, you know, it can be included, for example, the ERA, EMMA, and ELIS to rule out a uterine factor. And also some patients do want the immune test I've just mentioned to rule out an immunologic problem. So you might have a patient in front of you who wants to rule out everything. And clearly, if a patient wants to rule out everything, then you know, these are the tests that might come to help. The ERA, EMMA, and ELIS on one side, and the immune investigation on another side. but it's also important, again, to know a bit more of the history of the patient, how many treatments she had before finding this perfect embryo, if she had recurrent failures before. That will enable the clinician to tailor the test better.
Okay, so the final question here is, my husband has poor sperm and it's ICSI that they are looking to do. Is there anything we can do before ICSI regards getting pregnant?
Yes, I mean, that's what we do here. Nutrition is not only important for women, it's also important for men, because some of the sperm problems can be improved with a healthy lifestyle. So some regular physical exercise, reducing the known sources of stress for the sperm, improving the diet, reducing the alcohol and coffee intake, taking
what
right
about tests?
Sorry?
What about tests on sperm?
Well, I mean,
DNA and various things like that.
Exactly. The test which is supposed to better address whether the sperm might have some issues is testing, apart from the semen analysis, which gives you a rough measure of what the problem could be. But if you want a better insight about the quality of the sperm, actually, the DNA, testing the DNA damage in the sperm seems to be, at the moment, one of the most reliable tests. Although still controversial, like pretty much everything in our field.
Yeah.
But it would seem a good indicator, at least as to whether there might be room for intervention with the supplements. And because if we manage to reduce the amount of damage on the DNA sperm, actually we would expect that sperm to work better, even if we are considering ICSI.
Yeah, because it's interesting, isn't it? Because like women, they're taking all the vitamins, they're doing everything. And sometimes for men, they're told, oh, you only need one sperm and we can do ICSI. But it's the DNA that's really important,
Exactly.
isn't it?
Well, I don't agree with that. Yeah, you're right. Sometimes, you know, there is the concept that, you know, you just need one sperm, so it doesn't matter what you do. But actually, that one sperm can produce better embryos if we have taken care about the preparation in that man, rather than if we don't do anything.
Yeah, no, I agree. Well, I've come to the end of my questions and we've come to the end of our session. It's gone very, very quickly, Simone. So what I'm going to be doing next week, because you're going to have to sign off on this, I'm going to be doing a whole thing for preparation for IVF. So on Monday, I'm going to go through everything you need to do to prepare. I'm going to be on my own. Then I'm hoping to have a nutritionist on Tuesday, an acupuncturist on Wednesday, and then we have King George, Dr. Ndukwe, on Thursday. So please join and we'll talk about everything you need to do for preparation, and any questions you've got, please DM in. Okay, thank you so much, Simone, for giving up your time this evening, and I hope to see you soon.
My pleasure.
Okay, take care, Simone. Bye-bye.
Bye.